I've been writing about health since the late 80s and about technology and computers since the mid 80s. So when people started talking about electronic patient records, the two interests that I had sort of merged. So I was sort of, oh, that's going to be interesting. And very much to my surprise, I noticed that there was hardly any discussion about the premises, how it would be organized, how it would be protected, how it would be used. The only thing I read, both in medical records and in technology magazines, was basically press releases. We signed a new contract between hospital so-and-so and Volmac, IBM, whatever. It's going to be even bigger, it's going to be even more wonderful, we can do so-and-so. And it was just basically PR that I saw. So once we actually were going to get started with an electronic patient record system in the Netherlands, and actually a national one, I thought it was time to really start examining the issue. And I was, well, rather dumbfounded to see what I found. The notion is that you would make medical information accessible nationwide. So instead of you going to a GP who sends you off to a hospital who then needs to ask a GP via letter what actually was the matter, the people in the hospital would have your information at their fingertips. So that all health information professionals would have the same information, and they can get it without any delay, without paperwork, without needing to make phone calls or what have you. That would force hospitals and GPs, dentists, pharmacies and what have you to cooperate, to share, and of course it would greatly help reduce costs, increase efficiency, while the whole, you know, this sort of charm. And most of all, it would reduce medical errors. Medical errors at that point were sort of being, there was some kind of research, most of it was taken from the US, and then it was sort of explained in Dutch terms. And the funny thing about the numbers that were given, it was sort of 1,800 cases of medical errors due to lack of information and cooperation between professionals, was sort of estimated at 1,800 per year. But slowly, in reports, the numbers started increasing, still based on the same research. So everybody actually inflated the number to quite some degree. But those people would be safe in the future. This is sort of the old situation. You have a pharmacy that gets you the information from the hospital, the specialist gives it to the GP, and everything went at a snail's pace. Very complicated and very inefficient. And this was the new wonderful situation. We would have a national exchange point that would track which data was kept where, and then as a GP, you would sort of ask the hospital via the switchboard for the information. It would stay there, and so only the hospital could change it, but the GP could see it, the dentist could see it in case that was necessary, and the pharmacy could. So the data would be stored where it was created, and you could access it in real time using the internet. Wonderful. One problem that arose is, of course, that patients need to be unique. And in the early 90s, when we started this whole system, the Secretary of Health, Alice Bosch, said, we will not use social security numbers for obvious reasons, as in making it too easy to collide different sets of data and, well, to make people too traceable and for privacy reasons. And what happened in 2006, of course, we used our social security number, which was then sort of split up, the number still being the same. It was split up in a social security number for work, taxes and welfare, an education number, and a health number. All the same number, just used in different areas. And, of course, all the unwanted, unforeseen, unaccounted for linking of personal data in many various domains was becoming a problem. Also, more and more, at the time, nobody thought about it, but identity theft is becoming a big problem as well. When all your data is, now all your possibilities and your sort of, your existence in various disciplines is dependent upon a number, the number becomes more valuable, especially for people who don't have access to all these areas. So identity theft is becoming a bigger problem. And another big problem was extending the law with regards to data linking. From the start, this new civil number was meant to assist law enforcement and investigation. which is especially weird when it concerns medical issues, because medical issues have always been very much protected from being used by investigators, you know, as in doctors actually, they can't say that guy probably did some kind of crime and here's his data. No, they have quite some secrecy laws in place, which to some degree are suddenly lifted by this new social security number. And there had been technical problems, or just errors. In March 2005, there was this hospital in the north of the Netherlands, east of the Netherlands, Spaarne, and they had done quite some digitalization of their patient records, and suddenly in their outpatient clinics, one computer started having problems, and that accelerated, and more computers started having problems. And they cleaned the first computer, but then more computers got the problem, to the point that all data was becoming so slow to access, they had to shut down outpatient visits. They had to shut down the outpatient clinics for a week in order to clean all the records and the computers. It took them quite some time. And they were brave because they announced it in the press. There have been more of such similar incidents and people never comment upon it, and they don't give out a press release about it. For instance, there are various radiology departments which have been having bugs and which found that the previous information on patient records were not available to them because of a virus, or sometimes were damaged, or sometimes were inaccessible. We've had a bug that's, there was a press release about it, but the press release was very, very, well, it was very little release in it. It was just the press saying there was a problem and you could not figure out what happened. But as it turned out, there was a bug in a program that calculated dosages for chemotherapy in a particular kind of software program. People were getting chemotherapy dosages 10 times too high. And rumor has it that indeed one person has died of this. And more there were data entry errors. One of the complicated things is you get these drop-down menus where you select the code for the disease or the code for the medication that you're going to give, and the drop-down menu where you say it's 10 milligram or it's 20 milligram. And invariably people take the wrong selection. They have one too high or one too low, and that's going to be in your record. There is another error where people simply are not used, they're not used to work with these programs. It might sort of become better in future, but people enter data in two different places, thinking, yeah, but it should be there as well, not knowing that the program will do it for them. Thereby, they up the doses twice. At the moment, electronic medication programs are currently the fourth cause of new medical errors. Well, actually, they were intended to solve these problems. So there you go. And there was this other problem, a sort of management problem. The Department of Health would allot no extra money for new software or the implementation of electronic patient records. The National Health Inspections would not give us a requirement set for this is how you're going to protect your data, this is how you're going to do it, this is the kind of software that you must use. The market will solve it. Nictis, the guys making this sort of hub in the middle, the switch point, they said, yeah, but the responsibility for the data and the software that people use to connect to us, well, that's their problem, not ours. GPs very often have no knowledge and no infrastructure to sort of set up their own software and their computers, and especially hospitals have lots and lots and lots of legacy software, which makes it very difficult to implement new software that is sort of safe, secure, and bug-free. And of course, the healthcare sector is not very computer savvy. And actually, they're not much bent on privacy, they're bent on sharing information. That's sort of the deal that they're in. So I thought, yeah, well, this whole list of objections, and yeah, nobody's going to listen. So what I did, I knew quite a number of people in the healthcare system, and I knew quite a number of hackers, so I thought, I negotiated with 3 hospitals, of which 2 agreed. One was a regional hospital, also providing electronic patient record services for GPs, for a nursing home, a revalidation clinic, And they serviced lots and lots of people. Their records were huge. And the other one was one of the biggest academic hospitals in the Netherlands. And I signed contracts with them. I would do a test, how secure their data was, how, well, a penetration test, basically. And the results were rather shattering. The academic hospital, actually, it was difficult to get in. We got into one of the remote servers that they found out immediately. The next morning I got this phone call. I found this hacker and he said to phone you. What the fuck is going on? And I said, there's a story to it. And you might refer to your board, but I'll tell you so and so and so. Actually, we couldn't get in. We could get some information, for instance, a workers directory, which proved helpful to do a social engineering test. That hospital, they sort of, were okay. The other hospital, Hospital A, they said, we're so happy to be part of this test. We really would like to see proven how secure our firewall is. And when we heard that the security depended on the firewall, we thought, oh. Within a couple of hours, we were in using SQL inject. They didn't know. We moved data around from the one place to sort of sloshing it around there, and they never noticed. They really had no clue. And I'll show you what I got, amongst others. Huge files of all the patients. I could ask the hackers, give me a list of so-and-so. Everybody living in so-and-so. Everybody over 55, everybody under 44. Give me people sorted by disease. I had the codes for the disease. After all, we plucked them from the database. Yeah, okay. And the really bad thing is, it was 1.2 million people, 8% of the Dutch population. The really bad point is, I couldn't not only copy them, I could not only delete them, I could change them. And if I was less reliable than I am, I could do something very, very complicated. For instance, change the blood type of everybody whose third letter in their surname is a vowel. People would start dying and nobody would have any clue why they're, well, you get the drift. This is one of our hackers sitting in Hospital B. They got in. They had security codes and they got what they wanted. They left with 8,000 patient record files. The Secretary of Health, no, this mustn't happen and we're going to do everything in our power and blah-de-blah, you know the drill. They sent a letter to Parliament afterwards. The implementation of the national, the switchboard was sort of postponed. Security suddenly was mentioned 27 times. It was never mentioned before. There was this new set of safety rules which would become a touchstone. Then again, it was very much blah-de-blah. Also, as in explaining about the linings that you would have in the hospital corridors, that kind of safety prerequisites. And fortunately, they said that the law on medical secrecy might need to be reassessed because, of course, suddenly system admins, data entries, outsourced companies have access to patient records files while they're not bound to medical secrecy. And everything went wrong on all the wrong levels. Hospital A, with the 1.2 million files, sent us the sysadmin, not the members of the board, while Hospital B actually sent the member of the board, and they started a full awareness training in the whole hospital. Actually, they even put themselves out. They said, we were Hospital B, Erasmus Hospital in the Netherlands. They retrained everybody. So what we have, huge problems, viruses, bugs, hacks. Improvement of healthcare is very dubious. Protection of highly sensitive data is severely lacking, and we still have many hospitals running Windows 97. What we should do, well, you can read, compartmentalized data. That's very, very important. Better architecture and privacy as the alpha and omega, not a sort of layer that you put over everything else. Trained personnel. We need data hygiene. There was Semmelweis, this guy who actually said, if you want to deliver a baby, you would start by washing your hands and instructing medical personnel how to be hygienic. Hygienic? Yeah. Data hygiene, that's what we need. And sloppiness should be dirty. A final thing. We have new problems. We are going to make much more medical appliances, pacemakers, insulin pumps. As it turns out, these can and are being hacked. At a presentation in 2008, people presented a pacemaker that they actually could switch off under the title, "Excuse me while I switch off your pacemaker." At the time, the cost of making the appliance, well, the cost of making the hack was $1,000. The company making the pacemakers knew about the problem and said, yeah, nobody's going to do it. 5 years later, the problem still existed, and by then it cost you only $10 to switch off somebody's pacemaker. Actually, there's quite some discussion that this might serve as a sort of new terrorist or even a new anti-insurgency measure. If you know that bin Laden has an insulin pump, you just turn it off. Yeah. That's the DEFCON thing, yeah. Beware and stay healthy.